physicians, medical colleagues, nurses, whoever else is in the room. I'm Jamie, or Dr. Rutland. I'm one of the pulmonary critical care physicians for Pacific Pulmonary Medical Group. Is the mic too loud, or we're okay with it? We're good? Okay. So we're a private practice group. We're also associated with University of California, Riverside School of Medicine. And so we teach, we run their internal medicine residency program in terms of the critical care and the pulmonary aspect. And so I'm an assistant clinical professor there. And just a couple of financial disclosures that I do have. I am on the Speakers Bureau at Genentech, as well as at AstraZeneca, and also at Cheetah Medical. A little bit about myself. I grew up in Sacramento. I went to Catholic school my entire life, kindergarten to 12th grade. And then I went to UC Davis for college, University of Iowa for medical school and residency. And then I went to KU Hospital in Kansas City for fellowship, which is where I kind of fell in love with interstitial lung disease and imaging because we had an ILD center there. And then my wife, as everybody knows, she said, if we go back to California, I want to be near the beach. So we're near the beach with our two little girls. So whenever I start giving a lecture, I always start off with a case because I think it's always pertinent and it's easier to apply. So when I first started here in 2015, 3 years ago, I knew that I wanted to build an interstitial lung disease clinic and an interstitial lung disease program just based on my love that I had during fellowship. However, I didn't really know how common it was going to be. And it was my first week on the job. I met a 62-year-old who had presented to the hospital on a multitude of occasions. She had shortness of breath and cough. The cough would never subside. It was non-productive in nature. And once she was admitted to the hospital, she would always be given steroids, antibiotics, and inhalers. And every time she was discharged with COPD and asthma. She'd been seen in my clinic, I think, once before I had arrived and treated for COPD. In August of 2015, when I'd been at my clinic for a month and I was moving into the hospital, she was admitted for shortness of breath and cough again. She was given a diagnosis of COPD and started on steroids. I went to her bedside. I saw her. I looked at her CAT scan. And here's her high-resolution chest CT. And what you can see on this, and we'll kind of go over some of the markings of a high-resolution chest CT, is you know typically that on a CAT scan when you're looking at the lung is supposed to be really black. And you can see these areas of whiteness and increased lung attenuation, which are just increased reticular findings. You can see the increased reticular findings in the bases, and you can see a slight presence of fibrotic bronchiectasis, which we'll kind of go over as well. And so my first inclination was, this is not somebody with COPD, especially because of the fact that this lady had never smoked a cigarette in her life and really had no lung issues whatsoever until she was about 50 years old. So in February of 16, her CAT scan had progressed, and you can see the increased reticulations, now the ground glass opacities that looked more consolidating. So the question that always comes to mind whenever we see CAT scans like this are, what's the workup? What are we thinking? What should we have tested? What should be tested? What could we have done, and what did we do? And what happened during her hospital course and going forward? And we'll revisit this throughout the lecture. So what I hope to obtain today is the definition of interstitial lung disease. We're going to talk about the interstitium in the lung, what exactly it is. We are going to talk about immunology because it's extremely important because it pertains to interstitial lung disease. We'll talk about high-resolution chest CT and findings, and we'll talk about idiopathic pulmonary fibrosis, the most common of the idiopathic interstitial lung diseases. And we'll talk about some other ILDs, and then we'll talk about therapy. So the pulmonary interstitium, as you guys all know, is a collection of support tissues within the lung that includes the alveolar epithelium, capillary endothelium, basement membrane, perilymphatic tissues. So when you think about the interstitium, it encompasses the basic unit of the lung, which is the secondary pulmonary lobule. Now, this cartoon diagram I find extremely helpful. Again, as that bronchiole is traveling down, it breaks up. You have your bronchial, your pulmonary artery, your pulmonary vein, and your lymphatic system are traveling with it, and they all lead to the alveoli stacked on top of one another. And it's separated by interlobular septa. Now what you'll notice is throughout the interlobular septa and around the bronchovascular bundle, you can see the lymphatic system traveling with the bronchovascular bundle and in the interlobular septa. Again, there are representatives of the pulmonary veins, the lymphatics, the pulmonary arteries, bronchioles. They're all within this secondary pulmonary lobule. When you look at it from a CAT scan standpoint, you can see the septa here, bronchiole, pulmonary artery, here are the pulmonary veins, and then you see the little circles in there, which are the alveoli stacked on top of one another. Again, normal lung histology looks like this. You got your pulmonary artery and your bronchus. You have your alveoli, your bronchioles throughout, and you can see the oxygen and air have a great path to travel through the bronchiole into the alveoli and to latch on to that red blood cell. When it diffuses across this membrane and gets on the red blood cell, you guys know the rest. Oxygen is used as the final electron acceptor, you get energy, so on and so forth. You're able to do your thing, so to speak. Taking that a step further, when you are looking at lung histology, there are type 1 and type 2 pneumocytes, which we all learned in med school. Type 2 pneumocytes are important because they produce surfactant, which is actually involved in the inflammatory process as well. And there's macrophages. Here's the macrophage here. So the macrophage monitors the lung, engulfs any particles that are abnormal that you're breathing in. I always like to, when I'm talking to my patients, I always like to tell them, remember, your lung is one of the only organs that's constantly exposed to the outside environment. All of these antigens that you're breathing in are in direct contact with your bloodstream at some point. So when you're looking at the histology of a normal lung, and you're looking at histology of interstitial lung disease, what are you seeing? You're seeing a bunch of immune cells. Those are those blue stained cells in the nuclei there. And they're all traveling throughout the interstitium, right at that capillary membrane, all in there. And then sometimes those immune cells will spill over into the alveoli. And the question is, why does this happen and how does this happen? So again, over the course of the last year and a half, I've kind of become an immunologist. I've read multiple immunology books because the immune system is extremely important in many different disease processes. When you think about sepsis and septic shock, it's an inflammatory cascade that leads to the over-exaggeration and the patient being so sick. When you think about ARDS, same thing. It's the immune system going haywire, so to speak. You have the innate immune system and the complement system that are activated first. Once they communicate with each other, and how they communicate are with cytokines, right? Nowadays, when you're looking at the new cancer drugs, you're looking at newer drugs, they're all targeting cytokines, which is the body's way of communicating with other cells. So then the adaptive immune system comes, the B cells, the T cells, and then they call over some more friends, and it leads to inflammation. Now, the inflammation in the lung is what's important. The point of emigration in the lung is that capillary membrane. So in other words, all of those white blood cells and all those inflammatory cells, they're going to enter the lung through the capillary membrane. That's just where we receive all of our oxygen, which is a huge problem. And every other organ, the kidney, the brain, the heart, the point of emigration for a white blood cell is in the postcapillary venule. Again, there are many different white blood cell types. And you might ask, why do I have this picture up of the T cells, the B cells, and then the NK cells? The reason I have this picture up is because what's important in inflammation and in interstitial lung disease, these receptors, the B cell receptor, the T cell receptor, the alpha beta receptor, the gamma epsilon receptors, there are so many different types of receptors. And so when the immune system is being activated or overactivated, what we're doing nowadays is we're targeting these receptors, or we're targeting the molecules that bind to these receptors, initiating that signal of the immune system. And we're going to get into that a little bit. When we're thinking about the idiopathic interstitial pneumonias, we first got organized with these in 2002. Before then, all of the pulmonologists would call it cryptogenic alveolitis. In 2002, a bunch of experts met And they decided to name these idiopathic interstitial pneumonias. And we all know idiopathic is unknown, but it's interesting. In 2013, they updated even further. And they have 8 basic types of idiopathic interstitial pneumonias. Idiopathic pulmonary fibrosis is by far the most common. Nonspecific interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, Desquamative interstitial pneumonia. Now, RBILD and DIP are a continuation of disease, and it's a smoking-related interstitial lung disease. So my question has always been, when I'm reading this, we call it idiopathic, but we clearly know what causes these two. So I don't know why we call these idiopathic, but we do. Cryptogenic organizing pneumonia, acute interstitial pneumonia, which is what ARDS looks like, lymphocytic interstitial pneumonia, and pleural parenchymal fibroelastosis. Translation, scarring of the pleura. IPF is the most common. And when you look at Meyer and colleagues, Travis and colleagues, Ragu and colleagues, 55% of the idiopathic interstitial pneumonias are IPF. We say over 100,000 patients in the US have IPF. I think it's much, much more. There's 42,000 new cases diagnosed annually. And this is what's a little bit scary for me, and I saw it when I first started here. 50%, 1 out of 2 patients start with an alternative diagnosis, which means they've been treated for something else, with something else for years. 38% of these IPF patients will see greater than 3 physicians before they actually obtain a diagnosis. The risk factors of IPF, male, greater than 50, smoking, are the obvious ones that you can see. And then there's genetic risk factors that you're not really going to be able to observe. This is the CAT scan of IPF, and what you're going to see on the HRCT findings is increased lung attenuation, which is increased whiteness that you can see here. Subpleural findings right next to the pleura. Reticular findings, which is that net-like that follows the secondary pulmonary lobule. And then honeycombing, which are those little black cysts stacked on top of one another. Now, we like to diagnose IPF with HRCTs so we don't have to get a biopsy. Reason is, when you get a biopsy, and if you biopsied something like this, a scar like this, people were getting persistent air leaks, and they would have pneumothoraces, and they would have chest tubes for days and weeks and months. So that's why we started to get more organized, at least with IPF, and we're doing a good job. You have to have these 4 findings for a UIP pattern, and then you have to have absence of features that are inconsistent with UIP. And this is kind of changing. So the features that are inconsistent with UIP, and I've got a picture on the next slide, upper and mid-lung predominance. So if these reticular findings are in the upper lobes, probably not UIP. Cysts, not cysts like honeycombing, but different kind of cysts. Ground glass opacities. Right? So ground glass opacities, whenever I see a ground glass opacity, I try to think, okay, what immune cells are in the lung right now, and how can I fix that? Mosaic attenuation. All mosaic attenuation means is in the areas of the lung where the pulmonary artery and the bronchiole are traveling together, mosaic attenuation, there are areas that will be more black than others or more white than others, and we call that, mosaicism. And you have to determine whether it's a blood vessel problem or if it's a lung parenchyma problem. Consolidation and micronodules. Now, the ATS came out with their CT findings for UIP in 2013. In November of 17, just a few months ago, Lynch and colleagues used the Fleischner Society and they changed the CT pattern a little bit. And basically, they took out possible and they went with probable UIP pattern. Right? If you have traction bronchiectasis, which we'll see an example of in a second, if honeycombing is absent and you have traction bronchiectasis and bronchiolexis, still probably UIP. We'll get into why. And then indeterminate findings really didn't change too much. But again, they're starting to go over and they're starting to realize that more of this is fibrosis than we think. You're going to get these fibroblastic foci. That's kind of the key word on any test if you're ever doing a CME online. Fibroblastic foci means idiopathic pulmonary fibrosis. And again, CAT scan findings got coronal and traditional axial views. Again, the lung attenuation. On a CAT scan, to be purely objective, there are increased lung attenuation and decreased lung attenuation. Linear reticular, nodular and nodules, parenchymal opacities, which you guys all see every day. You have your cysts, your emphysema, your bronchiectasis here, your mosaic attenuation, and your air trapping. So here are some examples of interstitial lung diseases. And so when you go through these CAT scan findings, you see the increased lung attenuation findings. This is subpleural findings here. That's more consolidative. This was actually somebody with an organizing pneumonia, and this was after treatment with steroids. You can see here the traction bronchiectasis or fibrotic bronchiectasis. Again, the way I like to think about this is you have that inflammation that's in the bronchiole and the scarring around that interstitium, and it just pulls the bronchiole open. That muscle can no longer contract as well. The arrows here, and it's not projecting very well. You can see the upper lobe findings here, increased reticulation. This is an area of black, a little bit lighter here. This is going with mosaic attenuation. When you see mosaic attenuation and increased reticulation in the upper lobes of the lung, that's going to lend toward more of a diagnosis of a chronic hypersensitivity or a hypersensitivity pneumonitis. Here in the pleura, there's the scarring. This is pleural parenchymal fibroelastosis here, and you can see the increased reticulation here right at that pleura in the upper lobe. When you're looking at this CAT scan, you see the ground glass opacity, and this has a classic appearance of somebody with an LIP. You have these cysts here, and if you were to biopsy this, you would see just a lot of lymphocytic infiltration, a lot of the white blood cells, whether they're B cells or T cells, that are going to be in this area. But these are, and then there's bronchiectasis here too. You can see that bronchiole being bigger than that pulmonary artery. Again, here you've got some bronchiectasis, a little bit of ground glass opacity that you can see around it. But it's just those interstitial findings that we're catching on CAT scan that are important. So when I see a patient, things I start to think about are a lot of the autoimmune diseases, and I'll just screen for them just by asking questions. And you'd be surprised how common these autoimmune diseases actually are. I'll ask somebody, if I saw this CAT scan here, I would ask somebody, do you have dry eyes and a dry mouth, which would lend towards Sjogren's syndrome. And Sjogren's, as we know, is lymphocytic infiltration of the glands, right? So you can also get that same lymphocytic infiltration in the lung. Eye redness or pain, uveitis and sarcoidosis, oral ulcers, lupus, ANCA-positive vasculitides, dysphagia, GERD, scleroderma, myositis, joint stiffness, rheumatoid arthritis. This is the most common one that I see a lot of. Skin tightness in the fingers. My patient that I initially presented to you guys in the beginning, she had skin tightness in the fingers and the face. Color changes in the fingertips, muscle pain. I always screen for hypersensitivity. Where do you work? Do you have a bird? What pets do you have? Do you own a farm? I also screen for extrapulmonary sarcoidosis. Are you 45 years old, African American, and you have heart block for some reason, right? That's where you got that lymphocytic infiltration of the pacemaker cells. Do you have stomach pain? You have liver disease. Again, muscle pain, joint pains, and weakness. Just screening, just using clinical history. In 2011, the guidelines produced by Talmadge King and colleagues, we would always want to order an ANA, a rheumatoid factor, and an anti-CCP, which is more specific for rheumatoid arthritis. And additional labs are based on the history and physical. But again, unless you're exposed to this, you really don't have an idea of what additional labs to order, and they weren't really published in their paper either. Pulmonary function testing is important, but as you guys all know, when you have scarring of the lung, you're going to have a restrictive lung defect. And a lot of times, these patients are going to have both an obstructive and a restrictive lung defect because they're probably smokers as well. So when I'm thinking about interstitial lung disease, there's a certain panel that I'll go through, and I generally, and I hate to say that I do this, but I generally just order all of these things. I'll check for common variable immune deficiency. I'll order an IgG, an IgE, an IgM, an IgA. I'll check for hypersensitivity pneumonitis by ordering the panel. I'll obtain inflammatory markers to see how inflamed their body is. I'll get an aldolase if I think they have muscle weakness. And then I'll get this extended ANA based on their clinical features. Do I think they have scleroderma? I'm going to get that SCL70. Do I think they have Sjogren's? I'm going to get that SSA and SSB. And so again, you have to have an understanding of some of the rheumatologic conditions, at least preliminarily, so that way you can funnel the patient to the right specialist to get the patient treated. Because a lot of times, we treat the autoimmune disease or the collagen vascular disease, you're also treating their ILD. Bronchoscopy, BAL cell count, and differential is important. An esophagram can be important as well. Now, when you look in the literature, GERD and IPF, a PPI is actually associated with improved survival. So on our 2015 guidelines, which I'll go over, we all recommend treatment with antacid. Again, sleep study. Obstructive sleep apnea worsens your GERD. So if you have scleroderma, you probably need to be tested for obstructive sleep apnea. And we always screen for secondary pulmonary hypertension. Again, as that lung scars down, that right heart has less healthy tissue to pump to. So of course it's going to feel that higher pressure. So this is all expected. When you're looking at the BAL, cell count and differential are extremely helpful. So it's always important to obtain that cytology. If you have a lymphocytosis, you can narrow it down a little bit. NSIP, HP if it's over 25%. Collagen vascular diseases will do this. COP will look like this. Lymphoproliferative disorders. Eosinophilia on that BAL as well. Again, Churg-Strauss, ABPA, parasites, neutrophilic cellular pattern, infection, asbestos does this, aspiration pneumonia does this, IPF does this as well. Going a step further with the lymphocytes, if you get CD1A cells, then it's going to be pulmonary Langerhans cell histiocytosis. Again, BAL is important. So always, always, always when you're doing the bronch, or if you know somebody did the bronch, just make sure that cytology is ordered to get that cell count and diff. Now, in some of the hospitals that I cover, I'll have problems getting that cell count and diff because their machines don't really can't count the cells in the BAL fluid, and they have to do it manually. But I ask them to do it, and they eventually will. Now, biopsy. Now, this is a big, it's not really a debate, but the question is, do we perform surgical lung biopsies for interstitial lung diseases? Now, this was published last year. The paper was kind of helpful. First of all, the mortality with surgical lung biopsy goes up the more oxygen you're on, obviously. So if you're not on any oxygen, mortality is anywhere from really 1% to 6%. Right? Certain papers, there are a few papers that are in the 4% range. Supplemental oxygen, 6%. If you're on mechanical ventilation, 75% mortality, you're probably not going to biopsy those patients. It's important to understand that 10% of those open lung biopsies are going to be non-diagnostic. 18% are going to be, you're going to be uncertain of the diagnosis with histopathology. So again, they're helpful, kind of. In the UK, they looked at 103 patients from 2008 to 2010. I really like this study. The clinical diagnosis is only concordant in 18%. But only 47% of the patients had their management, 47 patients had their management changed as a result of the biopsy. Over 50% of the patients didn't really have their therapy changed. Now, the way that I look at a biopsy might be a bit different. If I'm biopsying the lung, not only do I want to know the pattern, but I want to know what cells are involved specifically. Is it B cells? There's a drug for B cells to treat B cells, rituximab. Is it T cells? There's drugs for T cells. I always think about the rejection literature and giving anti-rejection meds. So when they did these biopsies, they're really looking for patterns. Cryptogenic, organizing pneumonia, or things like that. Again, the role of surgical lung biopsy, you can do some transbronchial biopsies with HRCT, and you might get a diagnosis in about 25% of the cases or so. What this paper did tell us was that with the fibrotic lung diseases, if you see areas of fibrosis, there's probably no need for biopsy. You know what you're going to see. You're going to see fibrosis. You're going to see the fibroblastic foci. So if you see a fibrotic HP, chronic HP, if you see IPF, if any of these are associated with fibrosis, you probably don't need the biopsy. If you think it's sarcoid or berylliosis or protein alveolar proteinosis, lymphangitic spread of cancer, or LAM, you can do a transbronchial biopsy. That's very helpful. This paper out of Japan was published in 2016. Some physicians like this paper. Some physicians don't like this paper. The lesson that I learned from this paper is what they did was they looked at 241 subjects, and they had 2 independent radiologists look at CAT scans. And they said, okay, is it possible UIP, or are these findings inconsistent with UIP? In the patients that had findings of inconsistent with UIP on their CAT scan, they looked at their biopsies. And 95% of them had a histologically or definite UIP, probable UIP, which I thought was interesting. So when they biopsied this, they saw fibroblastic foci. And that's not what's expected when you're looking at this CT scan. So it begs the question, really, what's the mechanism in the immunology of fibrosis? So with any injury, and Wynn and colleagues showed this in 2011, with any injury, you're going to get the clotting and coagulation, the inflammatory cell migration, and then certain cytokines are produced. And then you might recruit myofibroblasts, which are going to lay down fibroblasts and that collagen and that scarring. That's the proposed mechanism of fibrosis. Now, depending on which cytokines are recruited or called upon, is going to lead to the fibrosis or not. What we think happens is that fibrosis seems to be what's called the Th2 mechanism. So on T cells, your T helper cells have two pathways that they can go through. So they're T helper, and then there's Th1, which is more like a sarcoidosis type of thing. And then there's Th2, which includes certain cytokines, and then maybe fibrosis. When you're looking at NSIP, or non-specific interstitial pneumonia, which occurs in middle-aged women, you're going to have that traction bronchiectasis here in the lower lobes, some ground glass opacities, but their prognosis is great. So if you can give somebody a diagnosis of NSIP versus IPF, they're going to have a 10-year survival of about 73%, which is a lot better than the median survival of IPF, which we all know to be about 2.5 to 3 years. Again, even though this fits in the idiopathic interstitial pneumonias, the serologies are often positive for collagen vascular diseases. You're going to see a cellular infiltrate, and you might see fibrosis as well with this cellular infiltrate. Radiographically, again, you're going to see the ground glass opacities. You're not going to see honeycombing, but you have a good prognosis. Respiratory bronchiolitis, another idiopathic interstitial pneumonia, is a hypersensitivity lesion found in smokers. Basically, what happens when you smoke a cigarette, your macrophages start engulfing the material that's in the cigarette, and you get pigmented-laden macrophages in the bronchioles, and that's RB and RBILD. You'll get the pigmented-laden macrophages right in here. As it advances, if you continue to smoke, the pigmented-laden macrophages will spill over into the alveoli, and that's when it's called DIP, or Desquamative interstitial pneumonia. And you can see them here. Now, it used to be called alveolar macrophage pneumonia for obvious reasons, but again, it's the pigmented-laden macrophages that are the primary concern here. Steroids treats this really well, but the best treatment actually is obviously quitting smoking. Cryptogenic organizing pneumonia equals bronchiolitis. Obliterans organizing pneumonia equals organizing pneumonia. You guys all know the presentation. You're short of breath. Drugs can cause this, idiopathic as well, but the pathology is going to show granulation tissue in your terminal and your respiratory bronchioles. You might get what's called the atoll sign, which is ground glass opacity surrounded by consolidation. It's kind of the opposite of a sign that you can get with fungal pneumonia or aspergillus. Treatment is steroids, and you can use the French or the Epler protocol, and then there's evidence for other immunosuppressives as well. Hypersensitivity pneumonitis, another interstitial lung disease, but not classified as an idiopathic interstitial lung disease, is a lymphocytic alveolitis. When you're thinking about the hypersensitivity reactions that you guys all know in immunology, there's type 1, 2, 3, and 4. Type 1 is the IgE-mediated hypersensitivity. Type 2 is that antibody and antigen hypersensitivity. Type 3 is when you have those immune complexes that will invade some of the blood vessels, and type 4, the T cell hypersensitivity. Hypersensitivity pneumonitis is actually type 3 and maybe later on a type 4 hypersensitivity. Now, what we find in the literature, Morissette and colleagues showed this, Silva and colleagues showed this, is as the hypersensitivity pneumonitis becomes more chronic, you kind of switch from an initial Th1 morphology, which is interferon as a cytokine or IL-12 as a cytokine, to more of a Th2 morphology when you have interleukin-4 as a cytokine, which leads to more antibody production for Th2 and fibrosis. Again, removal of the antigen is the best treatment, But you can use steroids, azathioprine, or mycophenolate mofetil. The most recent paper was published in 2017. We looked at mycophenolate mofetil or azathioprine for the management of chronic HP. But again, removal of the antigen, if you can figure it out, is the best. Sarcoidosis. Sarcoidosis, development and accumulation of epithelioid granulomas associated with the mononuclear cell infiltration. Th1 response, interferon gamma, interleukin 12, interleukin 18. Again, these patients, African Americans, Europeans, are going to present with adenopathy. Sometimes you'll get this patient and they'll have diffuse lymphadenopathy. You'll think they have a cancer. You'll biopsy the node. It'll end up being sarcoid, and you're thankful for that. There are people that think that this is a chronic mycobacterial infection. Either way, you can treat it with steroids, and you can treat it with mycophenolate. There's some kind of case control studies that say that mycophenolate may be of benefit. The old school stages are based on the X-ray findings, right? Normal, bilateral hilar adenopathy, bilateral hyalinopathy with infiltrate, just an infiltrate, and then pulmonary fibrosis. The collagen vascular diseases have a better outcome than IPF, so I always try to look for these. They're going to mostly look like an NSIP pattern. Bilateral, ground glass opacities, you might see some traction bronchiectasis. All right, you have to be thinking of these diseases to diagnose them, and it's as simple as ordering an antibody test. Here's that bilateral ground glass opacities, and it's subtle. Sometimes it's subtle. If the radiologist is not used to looking for interstitial lung diseases, they may fly through the CAT scan, and they might say, oh, subtle ground glass opacities, maybe pneumonia. And that's okay, you're going to treat with pneumonia, but if the patient keeps returning and they continue to present to you with shortness of breath and shortness of breath 4 or 5 times a year, it might be something like this. Mycophenolate mofetil improves lung function in these patients. So my patients that have collagen vascular disease, I put them on mycophenolate, at least at first. The vasculitides, and they are a type 3 hypersensitivity. The ANCA positive small vessel vasculitides affect the lung. So you have the granulomatosis with polyangiitis, which used to be Wegener's. Eosinophilic granulomatosis with polyangiitis, used to be Church-Strauss. Again, these are all part of interstitial lung diseases as well. The treatment of them depends on how they affect other organs besides the lung, if the kidneys are involved or even the brain is involved. Cyclophosphamide, azathioprine, methotrexate, rituximab, plasmapheresis are the treatment for these. Other than idiopathic, pauciimmune, pulmonary capillaritis, which is just inflammation at the capillary bed causing diffuse alveolar hemorrhage, all the others are going to have extrapulmonary disease. There's a very nice paper written by King and colleagues about 4 years ago, which just was pulled out of. These are going to be your CAT scan findings. They're going to look cavitary, they're going to look consolidated. There are lots more diseases. Pulmonary Langerhans cell histiocytosis. It's a tiny cystic lung disease associated with smoking. LAM, which I've seen several times in the last year in the reproductive age females. Again, you're going to get thin-walled cysts like this. They might present with a spontaneous pneumothorax, and they're going to have smooth muscle proliferation. Eosinophilic pneumonias are important, especially nowadays with mepolizumab and benralizumab that can treat that IL-5 that recruits eosinophils from the marrow. Those are important. You diagnose those with BAL. There's well over 100 different forms of interstitial lung diseases, and we're just now kind of starting to get more and more organized. For me, this was a paper that came out last year. What's important, and I bring up this paper, again, what they looked at multidisciplinary teams versus a clinician versus a radiologist. What I find important about this paper is really the survival curve. Here's a survival curve for IPF, and here's a survival curve for non-IPF. So again, working these patients up, if they don't have an IPF, they don't have those IPF features, drastically changes their prognosis. Now we're going to move on to treating these interstitial lung diseases and or idiopathic pulmonary fibrosis. In 2014, the FDA approved 2 medicines, nintedanib and pirfenidone, to treat idiopathic pulmonary fibrosis based on their phase 3 studies that showed stabilization of an FVC over time, over 52 to 72 weeks. In 2015, we updated our guidelines when we came out with guidelines to treat IPF, and we said, don't use warfarin. That was what we used to use. Don't use a combination of prednisone, azathioprine, and NAC. Don't use the drugs that treat pulmonary arterial hypertension. Sildenafil, bosentan, macitentan. The way I like to think about this is, if you're a lung and you're scarred down, of course you're going to narrow your blood vessels to the areas that are scarred because that part of the lung doesn't work. If you go and you dilate those areas and you send blood to scarred lung, hypoxemia probably is going to worsen because the lung is already protecting itself and saying, hey, blood, go somewhere else. And again, when I was a fellow at KU, we would get a lot of these patients that had advanced interstitial lung diseases. Community pulmonologists didn't quite know what to do, so they would put them on ibuprofen because of pulmonary hypertension, and their hypoxemia would worsen. And so we would stop that, and I just saw a trend, patients would improve a little bit. So again, it made sense to me, at least pathologically. Use nintedanib, use pirfenidone, use antacids. And what you want to follow over time, obviously, is the patient's symptoms and their FVC and maybe their DLCO. 6-minute walk tests will correlate with disease severity as well. The mechanism of the drugs, and this is why the immune system is important, is they're inhibiting certain cytokines that are recruiting different types of immune cells, or they're inhibiting certain receptors that respond to different antigens or different cytokines because of the presence of certain types of immune cells. Pirfenidone hits many different cytokines. The important ones, TGF-beta inhibition, TNF-alpha inhibition, and it actually increases hepatocyte growth factor mRNA. So increased hepatocyte growth factor has been associated with less fibrosis. Nintedanib is a tyrosine kinase inhibitor, and it inhibits platelet-derived growth factor, vascular endothelial growth factor, and FGF as well. And all of these have been implicated in fibrosis, which is probably why the drugs work. Other medicines for interstitial lung disease in general, we're talking about inhibiting the immune cells from proliferating. Sirolimus inhibits the IL-2 receptor. IL-2 is an important cytokine that leads to a bunch of proteins that recruit T cells. T cells are the chronic inflammatory cells that are present in this interstitial lung disease. Tacrolimus inhibits IL-2 promotion as well by being a calcineurin inhibitor. Mycophenolate and azathioprine basically inhibit the production of more cells because they're DNA inhibitors. Rituximab is an anti-CD20. Again, when you biopsy these interstitial lung diseases, if you see a bunch of B cells, you might want to try rituximab because it may calm down that inflammation. The future drugs and future therapies are directed towards some of these mechanisms. We talked about mycophenolate. It's used in chronic HP. It's used in connective tissue disease. It's used in sarcoidosis. Azathioprine inhibits DNA, steroid sparing, and HP. It's also used in sarcoidosis. So the future of IPF and ILD. Again, what we notice for therapeutic targets, that hepatocyte growth factor, that tends to lend itself towards anti-fibrotic activity. Telomerase activity. Again, what we notice is as the chromosomes get shorter, as you get older, the aging process continues, and telomeres shorten, that leads to fibrosis. We notice that androgen increases telomere length. So there's a couple studies out there on supplementing androgen. Prostaglandin E2 tends to be anti-fibrotic. We'll talk about a study involving the inhalation of prostaglandin. PDGF inhibitors, TGF-beta inhibitors, integrin inhibitors. There are multiple drugs. This is a very, very nice paper published last year out of Nature. And it goes over the drugs that are in phase 1, 2, and 3. They're even using Bactrim, which suggests that there's a less mortality with cotrimoxazole, but it doesn't really alter your FVC or your DLCO. But there are multiple drugs in the pipeline. The drugs that were here were actually pirfenidone and nintedanib, and they have been approved. There's anti-connective tissue growth factor. There's PBI 4050, and they'll all have fancy names once they get approved, if they get approved. Again, we're talking about TGF-beta. We're talking about different interleukins. But we're talking about the immune system here. That's the important part. Here's your prostaglandin E2 inhalation. when you're looking at, and this was done by Ivanova and colleagues, they looked at healthy mice as a control. In a mouse model, we all use bleomycin to induce pulmonary fibrosis. And what they noticed was they would induce pulmonary fibrosis, they'd give these mice inhaled prostaglandin E2, and as you can see, the architecture starts to return. The immune cells start to go away, and normal lung architecture starts to return. So it's an interesting drug. This was published in 2012. Other drugs, they are starting to target two different receptors, two different cytokines, TGF-beta and platelet-derived growth factor. And again, when you look at this study, here's radiation therapy, which can cause fibrosis over the course of weeks. They added either a PDF inhibitor or a TGF-beta inhibitor, and then they combine the therapy, and you can see the normal lung architecture starts to remain. Just interesting studies that are coming out in the future. Going back to our patient, the 62-year-old that presented to the hospital on a multitude of occasions. So we did a bronchoscopy. She had 80% neutrophils. We ended up getting an ANA. It was 1 in 1280, which is extremely high. And she had anti-SCL70 positivity. So she had scleroderma. So I immediately put her on pirfenidone. Now somehow, in the 2 years that she was seen prior to my arrival, she had a lung biopsy, which I thought was interesting. And her lung biopsy had shown fibroblastic foci. So I actually put her on mycophenolate and I added pirfenidone. I referred her to UCLA. She had a lung transplant and she's doing very well. So the way I looked at it is sometimes you look at treating the fibrosis. You look at treating IPF or you look at treating ILD. Sometimes you want to keep a patient alive long enough so they can make it to definitive therapy, which is a lung transplant. So again, I hope I helped understand CT findings of ILD and IPF, how to work it up, the differential diagnosis, whether or not to biopsy. I think that in my practice, knowing that there are some cardiothoracic surgeons that are comfortable doing the biopsies, some maybe not so where I mostly practice, but if I have a question and the BAL didn't help, I will get a biopsy. If not, and I find a connective tissue disease, I won't get a biopsy and I'll start immunosuppressive management. I've got a rheumatologist that I work closely with and an immunologist that I work closely with. And we toss patients back and forth and we manage them. But again, sometimes that therapy is just keeping the patient alive long enough to make it through a transplant evaluation, which I found extremely beneficial to her and important.